A disease is a chaotic biological event. When a patient presents with an infection, it cascades across cellular tissue, triggering heat, swelling, and a dozen systemic alarms. To capture this clinical reality, physicians must document every aspect of what they observe. As a medical coder, your objective is to take that sprawling, complex clinical truth and translate it into the rigid, mathematical structure of the ICD-10-CM classification system. This translation process often creates friction for beginners. The immediate instinct is to take every single symptom written in the chart and assign it an individual code, assuming more codes equate to a more accurate record. In this mock progress note, the physician established a definitive primary diagnosis, acute appendicitis. Beneath it, associated symptoms are documented, right lower quadrant pain, and a fever. Do we map these three distinct clinical terms to three separate ICD-10 codes, or just one? The answer to that question is governed by ICD-10-CM guideline B.5. The rule is titled Conditions that are an integral part of a disease process. Professional coding requires knowing exactly when a clearly documented symptom should remain completely uncoded. Automatically assigning a code to every documented physical reaction does not yield a sharper clinical picture. It creates data bloat, generates redundant claims, and guarantees compliance failures. To apply this guideline correctly, we first have to define what the word integral means within the framework of ICD-10-CM. An integral symptom is a physical sign or response that is routinely associated with and forms a fundamental part of the disease itself. In clinical practice, this translates to predictable physical responses. A fever accompanying a severe infection is an integral symptom. Localized pain associated with tissue inflammation is an integral symptom. This structured alphanumeric block represents a definitive diagnosis code. We'll use J01.90 for acute sinusitis as our example. Think of this code as a container. Because fever and pain are routinely associated with acute sinusitis, they are seamlessly absorbed inside the primary diagnosis code itself. Once a definitive diagnosis is established by the medical provider, the alphanumeric code designated for that specific condition already captures and accounts for its routine symptoms. Therefore, adding separate symptom codes alongside the definitive diagnosis is entirely redundant. The ICD-10-CM classification system is intentionally designed to compress expected disease progression into single codes. This structural logic prevents infinite data expansion on medical claims. Translating this guideline into practice requires an objective, step-by-step tool. Coders cannot rely on subjective guessing when evaluating a chart. We can map this logic into a decision tree. The first trigger point asks, is there a definitive diagnosis? The very first step is verifying if the provider has actually established a confirmed diagnosis to attach the symptom to. If they haven't, you code the symptom. If they have, you move forward. The next logical filter addresses the core of guideline B.5. We must ask, is the symptom routinely associated with the disease? To rapidly evaluate this second decision node, we use a specific memory concept at AMCI. We call it an MJ gem. If it's expected, don't code it. You must evaluate the clinical documentation and ask if the symptom is a routine expectation for the patient's condition, or if it represents a clinically separate, unrelated issue. If your analysis determines the symptom is expected, the pathway leads to an immediate terminal stop. Do not assign a code. This terminal stop applies regardless of how heavily or vividly the physician documented the expected symptom in the medical chart. Testing for clinical expectation is the primary filter that separates accurate code assignment from redundant overcoding. There is a critical caveat to guideline B.5. The ICD-10-CM system contains explicit scenarios where this integral rule is overridden. General guidelines establish the baseline rules, but the classification manual itself, the tabular list and alphabetic index, serves as the ultimate authority. Does the classification explicitly instruct you to code the symptoms separately? You will see this as an explicit instruction in the tabular list, such as a note clearly stating, "Code also associated symptom." If this exception is triggered, you must follow the manual and assign the code. Now, look at what happens when this entire decision matrix is ignored. Failing to apply guideline B.5 creates immediate administrative and financial fallout. Modern billing systems use automated edits to catch redundancies. Coding an integral symptom alongside its primary disease leads straight to automatic claim denials and triggers compliance audits. Failing to recognize integral symptoms or ignoring explicit classification instructions shifts a coder's work from being helpful to being a definitive compliance liability. Here is the completed symptom processing decision tree. Let's look at the workflow from a high level. We will run a rapid test case through the algorithm to simulate a real-world coding scenario using a raw, documented symptom. Step 1. Input the symptom and verify a diagnosis exists. Yes. Step 2. Apply the MJ-GEM and verify the symptom is expected. Yes. Step 3. Check for explicit tabular instructions to code separately. None exist. The path terminates at do not code. Clinical documentation establishes the biological reality of the patient's condition, but the ICD-10-CM rules dictate the final code assignment. Executing this exact algorithm ensures your code selection is accurate, efficient, and audit-proof. That is the AMCI way. Integral stays included. A definitive diagnosis code is designed to be a complete clinical package. True coding mastery requires trusting the system to hold the expected data.